Welcome. So this talk is similar to one I gave last year, upper GI bleeding, and I think it's a relevant topic for the house staff, because you guys really are the first, or if you count the ED as the first line providers, you're like the second line providers for this, and you'll see a lot of this. And this is probably one of the most common reasons why you'll consult us. So, I'm happy to kind of talk about this topic, and we'll start with a few questions, and then we can go from there. All right. So we'll start with some questions, then we'll talk a little bit about upper GI bleeding and how you should approach it as medicine house staff, okay? So 55-year-old man is being evaluated after being hospitalized for epigastric pain and dark stools for the past 3 days associated with fatigue, no hematochezia, hemonemesis, chest pain, or shortness of breath, and has osteoarthritis treated with ibuprofen. Receives an IV fluid bolus in the ER. Those are his vital signs that you can see up on the screen. His physical exam has some epigastric tenderness, but nothing else, and his hemoglobin is 6.3. He undergoes an upper endoscopy, which shows an ulcer in the duodenal bulb. So which of the following is the most appropriate resuscitation measure? Anyone volunteer to answer? Which do you think is the correct option?
So does anyone want to go ahead and answer? You can unmute yourself, or you can post in the chat whether you think it's A, B, C, or D, if you're transfusing to a level of 8, 10, 12, or no transfusion in this case. If not, we'll pick a maybe not so lucky volunteer. So I see Cheryl is said B initially, and now Galit Jonas Donald also had option A, transfused to a goal above 8.
Yes, so that is correct. Transfusing to a goal of 8 is the correct answer, and we'll talk about why, where this data came from. But basically, the transfusion goal is 7 to 9. So this patient's hemoglobin is 6.5. You want to transfuse them. You want them to be above 7, but you don't want to over transfuse them to a hemoglobin of 10 or 12, because there was a study that showed that a restrictive transfusion strategy with a goal of 7 to 9 actually results in better outcomes compared to a more liberal strategy where you transfuse them to a hemoglobin of over 9. So 8 is right there in the middle of that range, and that's where we want him to be. Okay, so that's the correct answer to that. So upper GI bleeding accounts for 5% of all ER visits, but has a significant number of hospital admissions and healthcare spending costs every year. 90% of this is from non-variceal bleeding, though sometimes I guess in our hospital it doesn't seem like that, because we do have a robust population of cirrhotic patients that come in frequently. But actually 90% of upper GI bleeding is ulcer related or non-variceal related. Most of these are self-limited. So if you just put the patient on a PPI, they will resolve, conservatively, but obviously we see a selection bias because patients that need to get admitted for upper GI bleeding are generally the sicker ones, and many of these will require endoscopic intervention. So of our admitted patients, definitely, we intervene on a lot more than 20%, right? And most of them are not self-limited. Many of them require some intervention. Most of these patients are older and have multiple medical comorbidities, and their mortality can vary. It's significantly higher if a patient has recurrent bleeding or difficult to control bleeding. So questions that you guys should ask when you first see the patient, right, and you're taking this history. So you really want to find out what the duration of the bleeding is, because if someone is coming in anemic, not very sure if they are truly bleeding or not, and it's sort of been a slow drift down in their hemoglobin over like months. Say you have a normal hemoglobin from 2 years ago, and now they're coming in at 6 or 7, but it's kind of slowly been reducing over the past 2 years. That's very different from someone who had a hemoglobin of 15 on Monday and is coming in on Friday with a hemoglobin of 6, right? Because that's someone who's lost a lot of blood volume in a short duration of time. So really getting a sense of how long they've been bleeding for, when the last bleeding episode was, helps us kind of triage, how likely these patients are to need therapy during the endoscopy. So if they're actively bleeding, their last episode of bleeding was a few hours ago, that's useful information, because one, it tells us, could we be encountering a stomach full of blood? Do we want to give some medication to clean that out before we go in so we get a better look? How active is this bleeding versus, someone who bled 2 or 3 days ago and has now stopped, the likelihood that, you know, they will resolve with just a PPI is much higher. So that helps us triage. Then, you know, medication questions. So are they on NSAIDs? When was the last NSAID used? Are they on anticoagulants and antiplatelets? Very important for timing of endoscopy, because sometimes we will, you know, want to wait a little bit if they're on Plavix, or if they're on Eliquis or Xarelto or one of those. Then, you know, when you're asking them a history of liver disease, many patients don't know if they have liver disease, so you want to do a careful exam to look for jaundice, skin stigmata of chronic liver disease, as well as, you know, and then important other things are what their hemodynamic status is, how much resuscitation they might need before a procedure, are they able to protect their airway? When they get sedation, is there someone who's already kind of confused and altered from bleeding? And are they going to, you know, become very hypotensive or not be able to protect their airway under anesthesia? Those are important considerations. And then are they able to consent? And if not, who do we contact for consent for the procedure? Those are all important things to find out when you're first getting a history from them. Any questions about any of this? If you guys have questions, please feel free to step in and ask them at any time. This is an informal lecture, so you don't have to wait to the end. So some definitions when you call us, you know, for hematemesis, just understand that the picture that the person on the other end is getting in their mind is vomiting of red blood. If you call us, you know, for coffee grounds, like the blackish stuff that sometimes comes out of the NG tube that, you know, is not really that urgent, that's coffee grounds. But when you say hematemesis, we, you know, what we tend to picture is like red or maroon blood, which is obviously much more acute. Melena, you know, passage of lactary stools. You know, sometimes people get confused between what is maroon blood coming from the colon versus what is melena. Melena is like truly black, has a weird smell, sort of sticky in consistency. There shouldn't be, you know, any doubt in your minds as to what it looks like compared to like hematochezia, even if it's maroon hematochezia, because that's, you know, generally from a lower source. When you're calling us for anemia without any GI bleeding, don't say, you know, just call us and say, this person has iron deficiency anemia, and that's the reason for the consult. You know, if you say concern for bleeding, it means that you've seen overt bleeding. So, you know, just kind of try to differentiate those. So anemia is a good reason for a consult, and we're happy to scope those patients, but it's a little different from someone who's overtly bleeding in terms of the timeline and the acuity of the presentation. And then obviously, you know, anatomical definition, the ligament of Treitz differentiates whether this is upper or lower GI bleeding. So bottom one is hematemesis. That's what we picture when you call us and say X, Y, and Z is having hematemesis in the middle of the night. You know, this is someone we probably will need to come in for overnight, or, you know, a few hours later if it's already the early hours of the morning. This is coffee grounds, generally not that acute, possibly from esophagitis or gastritis, and will resolve with a PPI and doesn't always require a scope. Melena is, like I said, that black tarry sticky stool, and that is hematochezia, which sometimes I think, you know, some confusion exists. But even this maroon looking blood, that's not melena, that's hematochezia coming from the colon, possibly slightly higher up in the colon, but very different from the lower left picture, which is melena, which is coming probably from an upper source. And then the Guaiac test, which I'm happy to say that I don't see much of in the hospital anymore. It shouldn't be used inpatient, and you guys don't use it, which is good. And I've also stressed that to the non-teaching and the PA staff who continue to use it, but shouldn't be. All right. So, you know, causes of GI bleeding, you know, the vast majority are gastric and duodenal ulcers, right? You can see the blue and the purple boxes are gastric and duodenal ulcers, and that forms the big bulk of upper GI bleeds. Then not so small portion is varices, you know, which is also an important thing to consider, and then other rarer causes like esophagitis, Mallory-Weiss tears, you know, ulcers in other places like stomas and in the esophagus, and then various other causes like Dulafoy lesions and things like that, which are rarer. So what are the predictors of poor outcomes? if someone is coming in with hematochezia from an upper source, right, that's generally a predictor of a poor outcome, because that means they're bleeding very rapidly to produce red blood that's transiting through so quickly that it doesn't even have time to really get converted into melena and to be digested by the acid in the stomach into hematin. It's just straight away coming out. That's a brisk bleed, and that's someone we're very concerned about. Short duration of bleeding, and then someone who's coming in with a big drop in their crit over a relatively short period of time. And obviously people who are older and have other comorbidities like renal, cardiac, liver disease, as well as obviously those who are bleeding enough to, go into hypovolemic shock or hemorrhagic shock, are the ones we're worried about. So pre-endoscopy PPI, right? So the first question that you ask the ED or that we ask you is, are they on a PPI? So there's a good reason for this. This was a study that was published in the NEJM some years ago about the benefits of pre-endoscopy PPI. So what PPI use prior to endoscopy did was really it downstaged the lesion, which means that, we'll talk about the stages of ulcers and the Forest classification of ulcers, but it brought these high-risk lesions with either an actively or a spurting or actively bleeding vessel down to sort of the lower risk lesions, which are the ones that don't necessarily require endoscopic treatment. And it decreased, so as a result, because it did that, it decreased the need for endoscopic therapy, because the low risk lesions we don't really treat, whereas the high risk lesions we do. So pre-procedure, pre-endoscopy PPI helps to downstage the lesion. It didn't really, so you can see here the differences between the placebo group and the group that got the PPI. So in the placebo group, you had much more that had a higher percentage that had those active lesions or high-risk lesions with actively bleeding vessels or visible vessels, whereas in the PPI group, you had much more that had a clean-based ulcer, which is sort of a low-risk lesion for which we don't do endoscopic therapy. So that was the difference. That was the primary benefit from doing PPI pre-procedure. It didn't really, have much of a difference in reducing rebleeding rates, mortality. The mortality in the two groups was the same, as well as the need for surgery and blood transfusions was sort of the same between the two groups. So it didn't really change much of that. But that's sort of a good study to read. Whenever you guys are doing journal club, it's a little old at this point, but still a very relevant article to kind of go over. And then, like our first question talked about, how much should we be transfusing, right? So this was where that data came from, where that data comes from. Do we want to transfuse, give them sort of, how much blood do we want to give them? Do we want to be very liberal with our transfusion strategy, or do we want to be more restrictive? And this was a randomized control trial with 200 patients that were presenting with symptoms of upper GI bleeding, both Hemonemesis and melena, and they were randomized to a restrictive strategy where they were, a hemoglobin of around 7 versus a more liberal, which is the hemoglobin was greater than 9. And the primary outcome was to look at all-cause mortality. And you can see that those in the restrictive strategy, which is the top line, actually did much better, right? Their survival was higher compared to the liberal strategy. And, the benefit, so usually when we think about this, right, when you think about why this might be, when you think about cirrhotics, it makes sense because you don't want to over transfuse someone who has varices because you're actually increasing the pressure on those varices and they will bleed more. But the benefit was not just in cirrhotics, it was also in people with peptic ulcer bleeding. So that's important to remember. The only time that I would say there's sort of a little bit of a caveat to this is when the person is bleeding sort of in front of you and the CBC is not really reflecting how much blood they're losing, right? Because if you do a CBC on someone who then, like half an hour later vomits up about 1.5 liters of blood, that CBC done right at that time is not reflective of that blood that they've lost, because it's going to take a little while for, to get a true this thing by the time, the plasma sort of dilutes that hemoglobin, right? So it's that initial hemoglobin is not very indicative. So those people you might want to give a little bit more blood to. But in general, if they're not actively pouring out blood while you are seeing them, then you want to transfuse to a goal of between 7 to 9 and not over 8 or 9. So, okay, give me a sec. So then timing of endoscopy. Again, another study that came out in the NEJM last year a good study to read, but in terms of when do we want to time the endoscopy. And in general, the consensus is within 24 hours of presentation to the hospital. So this is where that comes from. The patients were randomized into two groups. The group that had an urgent EGD, that is within 6 hours of the GI consult service being consulted, and then early endoscopy that was done within 24 hours. And they looked, their primary endpoint was death, but they also looked at other parameters like further bleeding, the length of stay, need for ICU stay, and then need for emergency surgery, embolization, and blood transfusion. And you can see that there was no difference in mortality between the two groups, between the urgent and the early endoscopy group. And there was no difference in bleeding down the line between the two groups either. So, rebleeding within 30 days, right? So really the outcomes were no different. There was no difference in ICU stay or length of hospital stay in either of the two groups as well. So what's really, I think the message that this study gives is that in that initial period, what's really important is resuscitation of the patient. That's what really saves their life at that point. It's not, rushing in to do an endoscopy on someone who might be under resuscitated and then have a bad outcome from the procedure or the sort of hemodynamic and shifts that happen during anesthesia and during the endoscopy. You want to resuscitate them adequately and then scope them within that sort of 12 to 24 hour period after they are fully resuscitated, and do your endoscopic therapy to treat them. Any questions? Okay. All right. So when we talk about endoscopic, when you have someone who's admitted for an upper GI bleed and you sort of read our endoscopy reports after that, you'll find that we use this classification to kind of stratify the risk of these lesions. And this is the Forrest classification. It's pretty universally used. You'll see it in every endoscopy report that documents an ulcer. And it's important because, like we talked about earlier, right, the lesions that we consider high risk are the 1 and the 2A and 2B to some extent lesions. So 1A is an arterially spurting vessel, not something you will ever forget if you see. And 1B is sort of an active oozing of red blood, not spurting, but brisk oozing. Lesion 2A is a visible vessel, and 2B is an adherent clot. So these are the lesions we mostly apply endoscopic therapy to, so especially 1A, 1B, and 2A, right? So you see this on an endoscopy, you have to treat it, and you have to treat it with 2 modalities of treatment. So generally, we never use epinephrine injection alone. It's epinephrine plus either heat therapy or clips. And that's sort of the standard of care. And we'll do that for any of the lesions in the top row. The adherent clot is, there's different ways to approach it. One way is to sort of try to take off the clot and see what is underneath it. And different people approach the removal of the clot with different degrees of aggressiveness. Some people will just sort of flush it with a lot of water and see if it comes off. And then other people, will also, use a snare or a forceps to try to take it off and then see what's underneath. Whereas, sort of less aggressive endoscopists will say there's a good clot form there, there's no active bleeding, why take it off and sort of create a problem. And what you do here kind of depends on personal preference, what your setup is, what your backup is, what time of the day or night it is. And that, sort of maybe in the middle of the night, I wouldn't be so aggressive at removing a clot that's kind of holding fine and there's no active bleeding. But if it were daytime and there was IR and everyone else around, then I would say, okay, I'm going to try to take off this clot and see what's underneath so I can treat the stigmata that's underneath if there's a visible vessel or a spurting vessel underneath. And then, lesion 2C and lesion 3 are these sort of lesions that have a low risk of rebleeding even without any endoscopic therapy, so we don't do anything for them. And that is just a flat pigmented spot on the bottom of an ulcer or an ulcer with a clean base. So these are the rebleeding risks of these lesions in people who have not had endoscopic therapy. So you can see that the first 3 lesions, right, which is the top row, they have a really high rebleeding risk. So these are things you have to treat endoscopically. Whereas the bottom 2, the flat pigmented spot and the clean ulcer base, they really don't have much of a risk of rebleeding. So if you have these patients and we scope them in the morning and we tell you there's a clean based ulcer, you can discharge the patient that same afternoon. You don't have to keep them and slowly advance their diet and, watch them. Maybe slight caveat to that is if they've truly had a big bleed or they're going to restart anticoagulation, then maybe want to keep them for another day. But everyone else, if it's like a healthy person, came in having a lot of NSAIDs, had a big clean based ulcer, just give them a meal right after we finish the endoscopy, put them on an oral PPI and make sure they get follow-up and send them home the same day. You don't need to keep them in the hospital. Whereas if it's someone who had, sort of a spurting vessel or, even a big visible vessel, right? That's not the kind of person, you should discharge, like be in a massive hurry to discharge the next day. Maybe just keep them and watch them for 24 to 48 hours because that's the highest risk of rebleeding, and those high risk lesions you want to kind of keep an eye on at that time. So what do you do after the endoscopy, or after we scope this patient and we kind of write our little GI will sign off note, and you are stuck with them? So you want to find out what caused the ulcer. So if you have, if there's a good history of NSAID use, then that explains it. The most common causes of gastric and duodenal ulcers are H. pylori and NSAIDs. So, if you really don't find an etiology for what's causing it, then those are patients that you sort of want to keep on a PPI probably indefinitely, and then you want to do some further workup to figure out why they developed an ulcer. You want to test everyone for H. pylori. So, sometimes we'll biopsy them during the endoscopy itself. Sometimes if they're like having a massive bleed, we won't biopsy them at that time. And we'll ask you to just send a stool antigen or have them follow up with us. And though there is a chance that, the stool antigen will be false negative because they've been on a PPI, we should still send it if we haven't done endoscopic biopsies to check for HP. If there's NSAIDs, you want to make sure they stop the NSAID, they're not discharged on the NSAID, they understand that the NSAID caused the bleeding, and that they are careful not to take it. If they absolutely need it, like if they have severe RA or, whatever, some reason why they can't get off the NSAID, then please keep them on a PPI for as long as they're going to be on the NSAID. If they are on aspirin, they don't need it anymore for primary prevention, so just take it off. If they're on it for secondary prevention, then you can, depending on, again, what the forest class of the lesion was, you can restart it. Someone who has like a 1A or 1B lesion, I probably wouldn't restart it like for 24 to 48 hours. But again, if the patient has a recent stent, or, if the patient has a recent stent, you shouldn't stop the aspirin. I mean, we should just keep it on. But if their stent is old, but they have to go back on aspirin at some point, kind of think about what kind of ulcer it was. If it was a clean based ulcer, probably fine to start the aspirin right away. If it was something like an actively spurting vessel, maybe wait a couple of days before you restart it. Again, all of us will tell you recent stents, right? Absolutely do not stop their antiplatelets. We'll do the endoscopy on dual antiplatelets if they need it, because the mortality from in-stent thrombosis is generally much higher than from GI bleeding. So, don't stop those unless there's a very good reason. And then, like I said, idiopathic ulcers. So if you didn't find out why, what caused the ulcer, then just keep them on a PPI forever, because they're technically at risk to get one again if you stop it. Okay.
Sorry to cut across you, Dr. Simoes. I think Galit might have had a question maybe related to the last slide or the slide before that, if you want to.
Sure, go ahead.
Hi, Dr. Simoes. I'm Galit. It's regarding the timing of the endoscopy.
Yes.
You said that between 24 hours from the consult, but I've seen patients that get admitted for upper GI bleed that they don't get scoped inpatient, and I was wondering what's the criteria for that. If they don't bleed further, you don't scope them inpatient and we just refer, or?
Yeah, so if, so 80%, so that depends on, there are scoring systems, like the Glasgow Blatchford score, to kind of stratify what the likelihood of us finding anything to treat endoscopically is. But if someone has a bleed that seems to have resolved with medical management, and 80% of GI bleeds will resolve with just PPI alone, right? So if this is someone who is either very high risk for endoscopy due to other medical conditions, or is someone who is not very high risk, but their bleeding seems to have stopped, like they have multiple stable hemoglobins, they are not actively bleeding anymore, then that's sort of almost 100% going to be something that responded to a PPI and is not going to require any endoscopic therapy. So, the sort of risk versus benefit ratio of endoscopy is that if they are very high risk scope and you're not going to do any therapy, then do you want to do a diagnostic, put this patient through the risk of sedation for a diagnostic endoscopy? And the answer is sometimes no. If you're not going to treat any lesion, then why put them through the risk of sedation? So in those patients, we'll say just manage them medically, prefer conservative management, and just watch them to spare them sort of that risk. But if anyone who's continuing to bleed actively, is someone we would scope.
Okay. And I have a follow-up question.
Yeah.
When should we order a CTA?
So, for an upper GI bleed, you shouldn't really order a CTA. I mean, endoscopy is the first line of treatment. So unless someone is very high risk for getting an endoscopy, or they're massively exsanguinating where we don't think we'll be able to do anything, or they're not even stable enough to sedate, or they're in like hemorrhagic shock and you can't get their pressures up enough to like do an endoscopy to get them to like even a pressure of 100/60, and they're just pouring out blood, then that's someone who you should probably do a CTA on, because even if we did an endoscopy, there would just be so much blood, it would take hours and you may not have that kind of time. But outside of that setting, for upper GI bleeding, endoscopy is the first line of treatment. If it fails or someone rebleeds after we've done maximum sort of endoscopic therapy, then as a second line, and you want to, and we'll go over that in the ACG when we talk about the ACG guidelines, but if endoscopic therapy has failed and this person is rebleeding in spite of receiving 2 modalities of endoscopic treatment, then that is the person who should get a CTA for potentially embolization. So either someone who's bleeding so massively that you can't stabilize them to have an endoscopy, or someone who has failed endoscopic treatment. Those are the reasons to do a CTA for upper GI bleeding. For lower GI bleeding, it's sort of the same thing, but we will do a CTA earlier, because for lower GI bleeding, to do a colonoscopy, you need a prep. So if someone is bleeding so much so that they can't prep, then they should certainly get a CTA first, because we don't do unprepped colonoscopies. There's absolutely no utility to doing an unprepped colonoscopy. So if they're stable and they can prep, they should prep to do a colonoscopy the following day or within 24 to 48 hours. But if they're not stable and they're bleeding, and they, because of hemodynamic instability, they can't drink a prep for a colonoscopy the next day, then you should do a CTA up front for lower GI bleeding. So those are the 2 indications.
Thank you.
You're welcome. Okay, so this is a male athlete with chronic elbow pain from a sports injury who has severe heartburn and has an endoscopy which shows some esophagitis as well as these lesions in the stomach. What do you guys think the etiology is?
So Juan in the
Just
chat.
shout out anything.
So Juan in the chat started off saying option 2, acute NSAID gastritis, and that seems to be the unanimous choice for everyone.
Okay. Yes, that is correct. So NSAID gastritis has this characteristic appearance where you see multiple lesions, usually around the antrum and the pylorus, which can sometimes be linear and sometimes be sort of shallow ulcers. There's usually more than one. So these are patients, this is very characteristic of NSAID gastritis. These are not lesions we do any therapy for because these are shallow, there's no visible vessel, there's just sort of pigmented material at the bottom of these ulcers, but you see multiple ulcers. And I think a couple of the house staff were rotating with me on GI a couple of weeks ago when I was on service, and we had some we had someone with good NSAID gastritis, kind of very characteristic endoscopy pictures. Adrian and was with us, and he was. This is PGY1s or PGY2s?
Yeah, PGY1's interns.
PGY. Okay. So yeah, Adrian was rotating with us, and he, we had a good case of NSAID gastritis at that time. So it has this very typical appearance, and that's what it looks like. Okay, and then this is also something that comes up from time to time. We have these patients who come in with recurrent bleeding, right? So a woman is seen in the ED for her second episode of painless bloody stool. 1 month ago, she was evaluated for maroon stool. Hemoglobin at that time was 2 grams lower than her baseline. Her EGD was normal. Colonoscopy just showed some old blood, but no active bleeding. And she was observed for a few days and then discharged. And now she comes in with more dark stools, one this morning, one just a few hours ago, and then she has some coffee grounds in her NG tube that clear after some lavage. She had a colonoscopy 2 years ago where she had a single adenoma that was removed, and no family history of GI malignancies, no upper GI symptoms, doesn't use alcohol, only medication is a multivitamin. These are her vital signs and her physical exam. What would you like to do? Which of these tests?
So again, if anyone wants to unmute themselves to answer, you can also post in the chat if you prefer not to. Whatever option A, B, C, D, or E: colonoscopy, double balloon enteroscopy, EGD, technetium red blood cell scan, or a wireless capsule endoscopy.
Colonoscopy.
Yeah, so
Okay.
Richard's saying A, so it seems to be a bit more, right? Richard saying C, colonoscopy, and then in the chat, some saying option C, which is EGD, and some going for option D, the technetium red blood cell scan. So I'm kind of between those three.
Okay, so everyone who said C is correct. So the reason why the answer is an endoscopy, so he's just had a colonoscopy, right? He, on the last admission, he had a colonoscopy. There was some old blood, but no active bleeding. She had a colonoscopy. And then there was a colonoscopy done 2 years ago with just a single adenoma. So he had 2 colonoscopies within a 2-year period that didn't reveal a source. I mean, it could still be something very subtle like an AVM or something that was missed, but less likely. So the next step in the algorithm is sort of to repeat the endoscopy. And the reason is, when you have this overt sort of obscure bleeding, right? The person is overtly bleeding, but you don't know where it's coming from. The algorithm is endoscopy, colonoscopy, and then before you look at the small bowel, which is what the other options are, the double balloon, the red blood scan, and the capsule, you are supposed to repeat the endoscopy. And the reason for that is there are lesions in the proximal stomach that we miss, especially if if someone has some leftover blood or we don't get an excellent look. But sometimes even even if the stomach is clear, you can miss lesions in the proximal stomach. So in the gastric cardia, you sort of see when we do an endoscopy, kind of looking back on it, we turn the scope, what we call retroflexion, and look backwards. And sometimes, there are sort of blind spots where if you don't do a very careful exam and you don't clean very carefully, you can miss a lesion there. And these are usually small lesions, like not ulcers. Ulcers we generally see, but dolifoil lesions, if the person has an HH or a hiatal hernia, you can have big lesions you can have small ulcers in there called Cameron's ulcers that can bleed, or you can have AVMs in the proximal stomach that you will miss. So that's why, this is sort of a tricky question, but I did take these from, I think I took these from MixApp. So, you could be asked this. I mean, I guess they expect you to know this even for the medicine boards, that it's not, after you've done the endoscopy and you've done the colonoscopy, the next step is not to look at the small bowel, but it's actually to repeat the endoscopy in case you missed a lesion in the proximal stomach. And the reason this person doesn't need another colonoscopy is they've had 2 already within a 2-year period. One just found a small polyp that was removed. Small adenoma is not going to cause bleeding. And then, the most recent colonoscopy showed old blood, which is probably coming proximally from proximally, but no active source. Okay. So yeah, that's a picture of a dolifoil. Sometimes they're very subtle and they can be kind of hidden in the folds of the stomach and you can miss them. So that's the reason for doing the endoscopy again. So, ACG published guidelines earlier this year on upper GI bleeding, pretty much the same as their old guidelines, which is everything that we've talked about. The only new things were that routinely recommend pre-procedure erythromycin or Reglan infusion. So you'll see that we ask for this, especially if it's someone we're going to scope in the ICU with like a high likelihood of having a stomach full of blood, or someone who is like vomiting, having hemonemesis just a few hours ago. You want to give them Reglan or erythromycin. Please do it at least 30 to 40 minutes before the procedure, so it has time to work. It's very annoying to go into a stomach that's full of blood and clot and then have to spend like hours cleaning it out. It's just much nicer if the blood's gone down and you can actually see what's bleeding. All ulcers that have high-risk stigmata, like I talked about, 2 modes of hemostatic therapy. So you don't just do clips or just do epinephrine. Generally do 2 things. You'll do epi plus clips or epi plus, the bipolar cautery. The new thing is hemospray, which was not in the previous guidelines. It was recalled and now it's available again, but it's basically a hemostatic spray that just sort of forms a film over whatever's bleeding and gives temporary hemostasis. It doesn't work for more than 24 hours. So it's really a bridge to when someone's having a lot of bleeding and you can't even figure out what's bleeding because there's so much blood, you can use hemospray to sort of temporize them till you can either get them to IR or surgery for more definitive treatment. There's no consensus on how best to manage a Forest B. This is what I was talking about, which is an ulcer with an adherent clot. So you want to try to irrigate the clot and see what's underneath. But if that clot doesn't come off with irrigation, you don't have to use a snare or something to more aggressively take it out. You can just kind of let the clot be. I think, for me, like I said, it depends on timing of the endoscopy. If it's in the middle of the night, I probably wouldn't poke a clot and then have like a giant vessel erupt in my face at 2 a.m. But, if it was daytime or someone had to go back on like anticoagulation, which is going to destabilize that clot, then I'd probably try to take it off and treat whatever's underneath. The new guidelines sort of didn't reach a consensus should be used. Everyone needs to be on a post-procedure PPI, but most of us will tell you, please put them on a PPI. If they're bleeding enough to get admitted to the hospital, put them on a PPI. There's new clips that we can use for recurrent bleeding, over the scope clips or Vesco clips. They're cool. If you've ever seen one of them being deployed, they kind of look like a bear claw, and they grab a lot of, you can grab a bigger vessel than the usual through the scope clips can. So it's a useful modality of treatment. And then if endoscopic therapy fails, you want to send them to IR. So some fun facts. It takes about 100 to 200 cc's of blood to make melena, but very little blood can turn an FOBT positive, which is why we don't use it in the hospital, because it's not a sensitive test. And it's not useful for in-hospital active GI bleeding. 30% of patients with upper GI bleeding who are older will also have cardiac ischemia. So we often see elevated troponins, and we say call cardiology, and then cardiologists, they're fine, it's demand ischemia, and we do this little dance, and then finally the patient gets scoped and sometimes has an MI while they're being scoped, but hopefully not. Mallory-Weiss tears are much more common in alcoholics. That's because they're usually retching, and you're not always best at giving a history, but that's important to remember. And then if someone is having, vomiting blood and also having hematochezia, that means they're bleeding a lot. Obviously, it's coming out from both ends, and that is scary and has a high mortality. Most GI cancers don't cause overt bleeding. Most of the time, people present with anemia and not with overt bleeding. And that's because they bleed so slowly that you never actually see the blood. It's just occult bleeding, and just makes them anemic over time. Just quickly, because often it's hard to differentiate whether someone's having upper or lower GI bleeding. These are common causes of lower GI bleeds. The most common thing is diverticular and hemorrhoidal. We almost never do any therapy for either of these. If like endoscopic therapy, diverticular bleeds, it's hard to identify which diverticulum is bleeding. Usually you'll just see a colon full of blood and like hundreds of diverticuli, and you have no idea which one is bleeding. There's blood and clot everywhere, so it's hard to tell which is the culprit. Very, very rarely you can identify and treat the culprit diverticulum. Hemorrhoids, if they're big and they look engorged, it's sometimes our best guess that if there's nothing else, that sort of by exclusion is the cause of the bleeding. Older people with multiple cardiac conditions, some abdominal pain who then have bleeding, probably have ischemic colitis. You don't always need a scope to diagnose this. It'll show up on a CAT scan. If they have a history that's very suggestive, this should be high in your differential, and the management is supportive care with lots of hydration and preventing them from getting hypotensive. If someone has had a history of a recent colonoscopy and they have had a big polyp removed, this is something to remember, a post-polypectomy bleed. So, when you take off a polyp, you're essentially creating an ulcer. Sometimes there can be a vessel at the bottom of that ulcer, and that can bleed. So that's important to remember as a cause of lower GI bleeding. People who have a history of prostate cancer and get radiation, or cervical cancer and get radiation, can have radiation proctitis. Again, Cindy and Adrian, who were rotating with us a couple of weeks ago, saw some of this. So we had someone come in with history of prostate cancer with radiation and had radiation proctitis, which was making them have significant hematochezia. And then obviously if there's a history of ulcerative colitis, those people can bleed. Please remember, for ulcerative colitis patients, even if they're bleeding, put them on DVT prophylaxis. They need it. The risk of DVT is very high. Don't stop the DVT prophylaxis because they're bleeding unless they're literally exsanguinating to death. Usually their bleeding is slight. It's just from surface, mucosal sort of being denuded and ulcerated. They're not going to have significant bleeding. So please don't be nervous about putting them on DVT prophylaxis. Stool guaiac, this is my pet peeve, but I think you guys hardly use this, so I won't spend too much time on this. Don't use it inpatient. It's not an appropriate test. It's a colon cancer outpatient screening test, not an inpatient test. It was never tested for inpatient GI bleeding. That's not the appropriate use. Doing it on a DRE is the wrong way to do it. You're supposed to do it from 3 separate stool samples, not, the trauma of doing a DRE itself can make the test positive. It doesn't change the management inpatient. If someone is bleeding overtly, they need a scope. Unless there's a good reason for them not to be scoped. If they're not bleeding overtly, but they're anemic, they need a scope. It can be done outpatient. Doing an FOBT, other than putting your finger in their butt, is not achieving anything. Just do a regular DRE. That's quite sufficient. If you see melena, you see hematochezia, tell us that. If you see nothing, they're anemic with brown stool, but they're still anemic, so they still need a scope. It can just be done less urgently. This test can be positive from myriad other reasons. If you're having nasal bleeding or hemoptysis that you swallowed, or you ate a steak, or any of these can cause a positive FOBT. Not useful to have inpatient. You shouldn't even really be doing it outpatient for colon cancer screening. For your clinic patients, do a FIT test or a Cologuard. Those have much higher sensitivity. So if someone doesn't want to get a colonoscopy and they prefer stool testing in the outpatient setting in your primary care clinic, do a FIT test or a Cologuard instead. And then obviously we recommend colonoscopy as the first line for colon cancer screening, but the stool tests are pretty good as well. Don't use guaiac tests inpatient. And if anyone gives you trouble, send them to me. These are the 7 deadly sins that I will end with of GI, just because most of you guys don't do this, but these are things that we really, really, really don't want you to do because they are not, they just waste time. Don't consult us without seeing a patient. Don't consult anyone without seeing the patient. It is poor etiquette and makes us think less of you as a doctor. Don't do it. We want to think highly of you as doctors because you're all good doctors. Don't consult us for bleeding without doing a DRE. Obvious exceptions are if someone's vomiting up blood, don't subject that person to a DRE. Or if they're sitting in a pool of red blood, you should still do a DRE because there could be something that you could feel like a bleeding lesion, but it's less relevant if they're sitting in a pool of blood, that it's lower GI bleeding. If you're calling us for management of ascites, please make sure there's a tap with full fluid studies. It's hard for us to tell what the etiology of ascites is if there's no tap. So that has to be done before, and then we can help you manage it. Though most times you're pretty good at managing it with diuretics or whatever needs to be done. If it's malignant ascites, obviously not with diuretics, but with some other method, probably LVPs or a Tenkoff catheter or something if required. This is more from a workflow perspective. Obviously, if someone needs an urgent consult, call the consult at any time of the day or night. That's what we're there for. But if it's a non-urgent consult, just in terms of our workflow, and procedure timing. Earlier consults are so much better, especially on the weekends when we cover 2 hospitals, because it's very frustrating to be called at 3 p.m. for someone who has been sitting in the hospital for a while. When you're at St. Luke's and you just left, finished rounding at West, and then they're like, oh, we're calling you, and you're like, you know, it's just annoying. So just call us early in the day. Obviously, if someone comes into the ED in the afternoon and then that's the first you're hearing of the patient, that's totally fine, and call us at any time you need us. Don't promise the patient a procedure if you're not the one doing the procedure, because if there's this expectation that, you know, we will place a peg and then we see the patient and we're like, oh my God, we're never placing a peg in that person, they need hospice, then, you know, it's a very difficult discussion, because the family has then already thought, this family member is getting a peg. And then, you know, we're coming in and saying, no, they're not getting a peg. And then it creates all this confusion and upset and like bad feeling that didn't need to be there. Just say, we are consulting X, Y, and Z to see if you are a candidate for X, Y, and Z procedure. And don't say, you know, we're calling them to place the feeding tube, because then if we say, no, you are not going to get a feeding tube, then it becomes very difficult for family members to understand that. And then, you know, when you call us for LFTs, just do the basic serologies. You know, it's kind of important, because it's so much, we can give you more insight if we know what's causing the LFT elevations. If everything is still pending, then there's not much we can tell you, you know, that you don't already know from getting a history from the patient. Obviously, the exception to this is liver failure. If somebody's coming in and they are like wildly coagulopathic or encephalopathic and you think they're going to liver failure, don't wait for serologies to come back, call us right away, because that's someone that needs a transplant evaluation and we can help that happen quickly. So, you know, send the stuff off, send a Tylenol level, do all of that, you know, hepatitis B, Wilson's, everything that could cause acute liver failure, send that right away, but don't, you know, don't hesitate to call us as soon as this person comes in, because if they need a quick transfer in the middle of the night, we can make that happen. And that is all I have to say. Any questions are welcome.